introduction. It's a pleasure to be in Seoul, South Korea for the first time. My only regret is I'm having to fly out tomorrow to get to ESMO, so I can't see as much as I know, but I would enjoy seeing. I do have to do the disclaimer bit. I have in some of my studies that I've worked with companies, they've given me travel expense, writing support, honorarium, Celgene and Myriad, and I am going to be talking about some information tonight that is off-label in South Korea, but I think it's important data to share because it points to where I think we're heading in breast cancer. I think that the big bottom line message, and particularly in HER2-positive breast cancer, is that we really are at a point now where neoadjuvant administration of systemic therapy really is becoming the standard of care for patients, and I hope to convince you of that in my talk. Of course, neoadjuvant therapy in operable breast cancer is not new. NSABP, under the leadership of Dr. Fisher, back in the late 1980s, launched the B18 study, which was a study that was designed really to see if giving chemotherapy prior to surgery in the neoadjuvant setting, rather than operating first and then doing adjuvant therapy, would improve outcome. In this, at that time, chemotherapy was quite simple. It was AC times 4. But I think the thing that a lot of people miss about this study is that this was really designed as a superiority trial. The hypothesis was that neoadjuvant therapy would be more effective than adjuvant therapy. So this was actually set up as a superiority test based on years of preclinical work that Dr. Fisher had been doing. And the bottom line to the study was it really was negative. It did not show superiority of neoadjuvant therapy over adjuvant therapy. So it did not establish neoadjuvant therapy at that time as a standard of care. However, because the lines were superimposable, it did provide important information that one concern people had was that women might be being harmed by leaving the cancer in place to get therapy. It was not true that you could give your therapy before or after surgery with the same outcome. So it became an option for people to think about for women in larger breast tumors, so forth and so on. But the real important item that had a big research impact had to do with some of the secondary aims. The study hypothesized that patients who responded really well to the neoadjuvant chemotherapy might do better in terms of their long-term outcomes. And if we saw that, it might be a way we could use a surrogate short-term outcome like PCR to predict long-term benefit. And the other thing that was mentioned even back then was that perhaps the patients who did not respond as well might be appropriate for additional systemic therapy. And this was the study that clearly demonstrated that the minority of patients, this only amounted to about 13% of patients had a PCR, but they clearly did better than the women who might have had some regression but did not have all their disease go away. And so pathologic complete response became an endpoint that we spent 20-25 years of research trying to add therapies to push the PCR rates ever higher. And in 2011-2012, the FDA became interested in the possibility of pulling together all the groups that were doing neoadjuvant studies, larger neoadjuvant studies that had PCR and long-term outcomes, get them to pool their data to look to see if PCR might indeed predict for long-term outcomes. And again, these are occurs from Patty Cortazar's presentation in San Antonio in 2012 that showed that same pattern. Patients who have PCR clearly do better than those who do not have PCR. A minority, relatively speaking, of the patients have PCR, and so there's, there continues to be this interest in trying to increase the number of women in PCR and get that curve higher and higher. But when we looked at long-term outcomes, we really did not see the correlation that was hoped for. Interestingly enough, FDA decided to go ahead anyway they were sort of setting this up with the idea being they wanted to have a justification for accelerated approval based on a surrogate endpoint like PCR, but they decided to go ahead and basically sort of look for big jumps in PCR rate, more aggressive tumors where we had perhaps higher recurrences, so forth and so on. And shortly after they announced this, Roche Genentech moved very quickly to actually piece together studies that were not designed for this purpose, pull them together, and actually got accelerated approval for pertuzumab in the neoadjuvant setting. And this had a big impact on the US because there was already some interest in neoadjuvant therapy, but at this point, if you wanted to give your patient pertuzumab, the only way you could was to give neoadjuvant. So in the US, this approval caused a big shift in clinical practice over to neoadjuvant therapy. And the data that they gave the approval on came from two studies, primarily Neosphere and Trifina. Neosphere was the main study. This is a Luca Gianni study, basically in which patients got docetaxel combined with HER2-targeted antibodies. When it was trastuzumab, the PCR rate was 29%. When you added pertuzumab, it went up to 46%. When you substituted pertuzumab for trastuzumab, it was 24%. But the big was that there was this clear increase of about an absolute 16% by adding pertuzumab. Again, a thing that had another study that really was a safety study. There was no randomized question here. The Trifina study basically added pertuzumab to both the standard anthracycline taxane regimens as well as the TCH regimens, and showed this very high PCR rate, higher than what we were used to seeing in HER2-positive breast cancers that, again, really accelerated things. And when you look at breakout by whether the tumors were ER negative or ER positive, you could see, PCR rates of about 80%, very, very high in patients with ER negative, and even in ER positive. It was 50%. So this information really more or less established neoadjuvant therapy with pertuzumab, as I say, as a standard of care in the US. Now those studies would not have resulted in the accelerated approval if Roche had not already completed accrual to the large affinity study. This was a huge global study, 4,800 patients that basically allowed a number of chemotherapy regimens and isolated the benefit of adding pertuzumab to trastuzumab on chemotherapy. And the study was positive, but I think it was somewhat disappointing that the absolute improvements were not greater. In node-negative patients, you couldn't see any improvements at all. The benefits seemed to come from patients who were lymph node positive or who were hormone receptor negative, and you see the hazard rates about a 25% reduction in risk for recurrent disease, but that amounts to only about an absolute 3 or 4%. But this did result in by and large, largely global approval of pertuzumab as the adjuvant therapy. So the dual antibodies are, again, in the US, very much part of both the neoadjuvant and the adjuvant therapy of breast cancer. But, and I think that the study, particularly the affinity study, really points to what we were seeing is that we were now seeing that PCR patients, particularly with trastuzumab, with pertuzumab, are doing extremely well. And it's just not possible to add more therapy to try and get more and more women into the PCR group when we're already 50%, 75% already in that group. And now there's talk about trying to maybe de-escalate, to back off some of the more toxic aspects of the program. But it did still leave the problem of the patients who did not have a PCR, who continued to have a high event rate, and that, of course, was the focus of KATHERINE. This was a slide from 2012 when we were launching KATHERINE, basically outlined the rationale for the study. At that time, we knew that affinity was ongoing and that we were going to get that information on pertuzumab, but we really recognized then that the bar for further improvement was way too high to keep pursuing that method. There were no biomarkers available that could tell us which patients who were likely to recur, and the best thing we had was that our PCR patients did very, very well. The other critical thing at the time was we had a drug, TDM1, that had already shown to be efficacy in patients who had received trastuzumab and taxane in metastatic disease and had progressed. So this seemed like a very reasonable drug to look at in patients who had neoadjuvant trastuzumab and taxane and did not respond. The TDM1 was particularly compelling, again, because this data had come out just as we were planning, Catherine. Very large study that compared TDM1 with what was the standard at the time, and all the endpoints were positive, but the most impressive, I think, was the fact that in the second-line setting, TDM1 showed survival advantage over capecitabine lapatinib, which is very unusual, implying really significant activity, plus it was much better tolerated than capecitabine and lapatinib. So what was the Catherine design? Basically we were interested in entering patients who did not have PCR, so we expanded it to include patients with very advanced disease, women who presented with T4 tumors or N3 disease were eligible for the study. We did not attempt to specify specific regimens that patients had to receive, and I know there's been a question here, some confusion here in Korea about, well, could patients have TCHB? Yes, yeah, patients could have TCHB, they could have anthracycline taxane. We basically described those regimens. We just said they need to have a minimum amount of therapy to get into the trial. We also recognize that sometimes patients can't get that last cycle because of side effects, so we didn't want to have it so rigid that we lost patients. But this basically, the idea was to include patients who received standard neoadjuvant chemotherapy. We did want them to have had at least 6 cycles, so they got all their chemotherapy before they had surgery. You had a number of stratification factors that I won't read through. They make sense. Big tumor, operable versus inoperable, ER positive, ER negative, and then whether they received only trastuzumab or got trastuzumab plus another HER2 targeted therapy. It was critical that we had that for the US accrual, or we would have never put any patients on the trial. The randomization was straightforward. Patients completed basically the full year of trastuzumab that they normally get, 14 cycles versus TDM1. We also encouraged patients, because we knew that now we typically give radiation therapy and endocrine therapy during trastuzumab. We also encourage people to do the same with TDM1, even though it is a form of chemotherapy, so we had symmetry there. And the large majority, over 80% of the patients, did receive those things together. I think my mouse may have died. There we go. Real quickly, just to speak to the statistics, we had evidence from the Techno study reported by Mike Karanch that we could kind of expect non-PCR patients to have a 3-year IDFS of 70%. And we thought that if we took that up to 76.5%, that would be clinically meaningful. So we did the study to detect a hazard rate of 0.75. That would require us to have 384 events to detect that. But we did plan an interim analysis at about 2/3 of those events, which is what crossed the early reporting boundary. At the time we conducted the interim analysis, we have a little over 40 months of median follow-up. You can see virtually identical number of patients in each of the 2 treatment arms, 743 and 743. The mouse is not working very well. In terms of patient population, real quickly, about 20% of the women were young, under 40. We had just under 9% of the patients were Asian, largely coming from Hong Kong and Taiwan sites. Majority of the accrual took place in North America and Western Europe, and about 3/4 of the patients had an anthracycline as part of their neoadjuvant regimen. Next slide. It's not working. A quarter of our patients had inoperable disease when they presented. Not surprisingly, since we know PCR rates are higher in hormone receptor negative, we had fewer of those patients in the study. We had a little over 25% were ER negative, the remainder were ER positive. 80% of patients received trastuzumab, 20% dual antibodies, and the large majority of those were pertuzumab. We did allow, so you can see down here a list of some small molecule TKIs investigators had administered as well. And then just under half of the patients were node positive at the time of surgery. Now, when you look at the amount of residual disease in the breast at surgery, not surprisingly, about 2/3 of the patients had 2 centimeters or less of tumor, and 40% had 1 centimeter or less. I mean, HER2 positive is a responsive disease, but we did have some patients with T2 tumors and even some with T3, T4. 45% of the patients were node negative. When you added those with small tumors, when we looked to see how many patients had both small tumors and negative nodes, it was a little over 20%. So we did have significant number of patients with this very small amount of residual disease. And these are the Kaplan-Meier curves that showed really the striking results. The curves separated very early and continued to widen with follow-up. When you look at the number of events, it dropped from 165 down to 91, 22% down to 12%. A hazard ratio of 0.5, much more robust than what we had designed the study to see. And very importantly, even though our trastuzumab patients did a bit better, we had projected 70% 3-year IDFS, they were 77%, we still saw a very large benefit at absolute improvement of 11.3% up to 88%. Another striking thing to me about the Kaplan data is how consistent the point estimates are for benefit through all of the critical stratification variables. And because we had such a large effect, you can see most of the subsets don't even cross a 1, the upper boundary of 1, but you can see the hazard ratios are basically 0.5, whether you come in with operable or inoperable, whether you were ER positive, ER negative, whether you received 2 antibodies or 1 antibody, whether you had negative nodes after treatment or positive nodes. Age did not matter, race, ethnicity did not matter. In looking at the primary tumor, it does appear maybe that the small tumors didn't benefit quite as much. The hazard is 0.66, but when you combine that with the negative nodes, that really small group, you do see that patients on trastuzumab did well. Those patients are at lower risk for recurrence. They had a 3-year IDFS of 85%. But it improved to 90%, an absolute 5% improvement, even for these patients with very small amounts. And I get a lot of questions about this because in the US, Fraser Simmons really had championed the idea of the RCB scores and that RCB1s do just as well as PCRs. Well, he has looked at MD Anderson's data in the era of trastuzumab, and what he reports now is that doesn't hold for HER2 positive breast cancer. RCB1 patients look and track more like RCB2 patients in HER2 positive patients receiving trastuzumab. You have to have PCR to be in this very high risk group. So this is consistent with the Catherine data suggesting that even those patients with just a little bit of cancer probably should at least try the TDM1 to see what their tolerability will be because they can benefit from the therapy. This is the breakout of the IDFS events that, of course, shows that distant recurrences were the predominant problem. They were substantially reduced. This does speak to the one failure, I guess, of TDM1. It really does not impact on CNS mets, and that still remains an unmet need. But in spite of that, clear reduction in overall metastasis systemically dropping from 11.6 to 4.6%. Local regional recurrences way down, contralateral breast cancer also down, interestingly. When you look at distant recurrence curves, cumulative distant recurrence curves look very similar to the IDFS curves. You can see the 3-year event-free rate for distant mets went from 83% up to 90%. Again, a very large benefit for this important endpoint. We did look at overall survival, not because we expected to see anything different, but because since we knew we had data that would require regulatory assessment, we needed to be able to show that there were fewer deaths in the TDM1 arm than the trastuzumab arm, and that clearly was the case, 42 versus 56. To speak to the toxicity data real quickly, I think it's important to remember that trastuzumab in these patients, these are patients who have already had trastuzumab for 6 months and tolerated it well, so they're going to tend to continue to tolerate it well. And TDM1 is chemotherapy, so it's not surprising we do see more toxicity with TDM1. We see that 20% of patients didn't complete trastuzumab. That went up to 30% of patients with TDM1, so about a 10% difference. 85% of patients tolerated TDM1 well, in spite of having all that prior recent chemotherapy, though we did have to do some dose reductions. When you look at grade 3 or greater AEs, 15% up to 26%, so it's higher, but this is not that high for a chemotherapeutic agent in an early breast cancer trial. Likewise, SAEs are up slightly. This is an important one that where there was a difference. We did not have patients stopping for formal adverse events in trastuzumab arm very often at all. We had 18% of patients stopping TDM1, but this was in large part due to some very conservative stopping rules that we had. Because at the time we weren't certain about hepatotoxicity, thrombocytopenia, and so a large number of these discontinuations were due to lab abnormalities that were asymptomatic, and the remainder were just a whole range of different things, no clear, consistent pattern. We were very happy to not see any evidence for increased cardiotoxicity. This is a slide that we prepared for San Antonio just to give that overall impression. It was, the dark colors reflect the grade 3 or 4 toxicities, and the blue is TDM1. And you can see there are really just these very tiny caps on the top of these bars, and most of them are in laboratory things like platelet count, AST increase. We did not see increase in radiation skin injury in spite of the concurrent administration. We did see, though, not surprisingly, a little bit more problems with sensory neuropathy. We are giving a little more granular data about those patients in terms of prior therapy here in the next few days at ESMO. So I do think, based on the striking efficacy and the tolerability data, that Catherine really does now challenge us to begin thinking of neoadjuvant therapy really more as a standard of care, because it is the only tool we have to identify these patients who can derive significant benefit from TDM1. And so I think that for patients who have T2 or greater primary, any nodal disease, when TDM1 is available, this really becomes a strong rationale for administering neoadjuvant therapy to find out who needs this, who can go on and complete their year of HER2-targeted therapy and doing well. Catherine quickly was accepted and adopted in the international guidelines, and NCCN AGO adopted it very, 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 very quickly. So wanted to shift for the last 15 minutes to triple negative breast cancer. This is the other major type of more aggressive breast cancer. We all are becoming increasingly aware of the molecular differences that are present in triple negative breast cancers. Triple negative breast cancers are, of course, not described by what they have, it's by what they don't have. They don't have ER, they don't have PR, they don't have HER2, so we lump them all together. And when you perform, people have looked at molecular genomic studies, there's really a high level of heterogeneity, and right now we're sort of going through the process of trying to identify the different subtypes into kind of a working format. These were the original 7 that were described by Dr. Lehman and colleagues. I just heard at Cisco, at Fudan, they developed a 4-member classification that also looks pretty robust. So I think we will see this continuing, but they do point out, some very basic, some significant differences. There's the basal-like group, which is more the typical triple-negative breast cancer. There's the subset of immunomodulatory that seem to be primed for possible benefit from PD-1, PD-L1 interaction. The mesenchymal stem cell types are very, very resistant, and they are probably the high-grade triple negatives that don't seem to respond well to chemotherapy. And then there's the androgen receptor group. And then basically what the Fudan group is sort of consolidating these. And there are alterations in the PI3 kinase PTEN pathway at about 0.25%, and somatic BRCA mutations in about 20%. Of course, the thing that we've been interested in over the past few years is looking at the TNBC group for that immunogenicity. There seems to have more characteristics consistent with tumors that respond to immune therapies than the other types. They tend to have more of the mutation loads. When you look at T-cell infiltrates, TILs, they tend to be the highest percentage of TILs, and even with PD-L1 expression, those seem to be higher as well. So it was a straightforward decision to study the PD-1, PD-L1 antibodies that interrupt this inactivating signal on T cells and can lead to T cell exhaustion. It's hard to imagine it's only been less than 3 years since Rita Nanda showed this graph at San Antonio that basically looked at pembrolizumab in women with advanced triple negative breast cancer. The response rate wasn't all that high, but this was a single agent therapy with a checkpoint inhibitor in breast cancer that was really exciting to see after we had been watching all the advances in melanoma, lung cancer, bladder cancer, and other tumor types. And the thing that was really, I think, for me, even more interesting about it was while it was a minority of patients who respond, when patients respond, it seems to be very durable, which is very unlike what we see with responses, the typical responses in triple-negative breast cancer. The PD-L1 atezolizumab was also looked at and reported on shortly thereafter. Again, a relatively low response rate, but you see amongst these responding patients this sense of durability again in the responses. And they showed subsequent long-term follow-up that showed in patients who have clinical response or PR or a partial response to the antibody therapy alone, they have this remarkable prolonged survival. And you see the patients who don't have that have the other triple negative, what we all see in our clinics and want so much to try and fix. The phase 1 studies had large expansion cohorts, and so there's substantial numbers of patients that have received single agent atezo and pembro in both first line and second line. And what we see in breast cancer and what we see in other tumor types, that early exposure seems to have a much substantially higher activity level than later exposure. Genentech was a little more aggressive in looking at preclinical models, combining their anti-PD-L1 inhibitor with chemotherapy, showing that this nice synergy. And they actually conducted took the time to do a phase 1b clinical trial that showed this remarkable waterfall plot. You know, these were patients newly diagnosed, so they're not heavily pretreated. This is so they're getting their first exposure to nab-paclitaxel for metastatic disease, but you see a remarkable, the high level of activity, very prolonged duration of response for many patients, and this survival curve that seems to be flattening out. So the rationale for conducting the Impassion 130 was pretty, I think, compelling, and that they decided to study nab-paclitaxel and use it as their chemotherapy backbone, comparing atezolizumab or placebo. Very large study, 900 patients. And the reason was, and I'll show you in a minute, they had rather complex design and statistical plan, but the Keynote 355 study evaluating pembrolizumab, really very, very similar. It is not yet reported, but as I understand it, we're supposed to be hearing about that at San Antonio. So Impassion 130 was a straightforward study of, as I said, of nab-paclitaxel administered on a day 1, 8, and 15 every 28-day schedule. They used a schedule of atezo placebo to allow them to administer that once every 4 weeks as well. They stratified by prior taxane use. Patients could have had prior taxanes in adjuvant therapy if they had had at least a 12-month recurrent-free interval. Liver mets, and then very importantly, PD-L1 status based on immunohistochemistry. And they set a relatively low bar for positivity of 1% with their SB142 assay prospectively based on previous work. This is the statistical plan that basically shows that they had co-primary endpoints of progression-free survival and overall survival. So they had to split their alpha of 0.05 into 0.01 for PFS and saving 0.04 for survival. They then wanted to look at both in the overall intention to treat population and the PD-L1 positive subset, and so they again split that alpha so they could look at both and report. If this was negative, they still were justified in going ahead and reporting this as significant. Because they preserved more of their alpha over here, and this was really the big ultimate endpoint, they decided to use a hierarchical plan where they would first look at ITT and then not analyze the PD-L1 positive group if this was not statistically significant, was what the plan said they were going to do. This was the report for the ITT population, and it was positive. The hazard rate was 0.8. You see a slight improvement in the 1-year progression-free survival, 5.5 months to 7.2 months, but this is really kind of disappointing, I think, for medical oncologists, if we're honest about it. When they looked at the PD-L1 positive subset, there was a better separation there, and we started to see meaningful differences at the 1-year progression-free survival endpoint, hazard rate of 0.62. So this was clearly very good to see that this PD-L1 positive group did so well. Of course, when the overall group just barely is there, and then a subset does real well, you wonder, well, what's going on with the PD-L1 negative group? And this is where, when they showed the data originally, you see the point estimate for the PD-L1 group was 0.95, suggesting that there was not a lot of benefit there, if any at all, that it might be segregating all to the PD-L1 positive group. And at San Antonio, they showed the two curves that were superimposable for the PD-L1 negative cohort. So this clearly is a drug that depends on PD-L1 staining of some magnitude, at baseline. When they went to look at the overall survival for the ITT population, you can see a little bit of separation, little bit of improvement there in terms of the numbers, 17.6 to 21 months, but this did not reach statistical significance. You see across one, and so they were not supposed to continue on and do the overall survival analysis, but they sort of did. They just didn't put a p-value on it, which I still don't personally completely understand, but it is what it is. The data is out there. And you see the Kaplan-Meier curves clearly show important things going on there. 15.5 months median overall survival out to 25 months. At ASCO this year, they reported a little more mature, and the 25 stayed for the PD-L1 positive group. This one moved up to about 18 months, but it's still significant with a hazard of 0.71. So there clearly does appear to be benefit to the PD-L1 positive population in terms of overall survival. And again, at San Antonio, they showed the negative cohort. No benefit at all. Lisa Emmons provided a little more closer look at the PD-L1 status question at San Antonio, and again, showing really there's a relatively low number of patients who have fairly strong staining of IC2-3, only 14%. Most of the positives were just were 1+, relatively weak staining. They looked to see how much of the SP142 was on tumor cells, and only 9% of tumor cells had staining. But when you broke that out and then looked at the immune cells, you saw that nearly all of the tumors that showed PD-L1 staining also showed it in the immune cells. So this is why this assay is done on the immune cells, not the tumor cells. And the interesting thing is, again, when you look at the forest plots, the hazard rate is very robust for the IC1s, maybe even a tiny bit better than the IC2-3s. So it really does seem like there's this threshold for just this tiny amount of PD-L1 positivity that results in the activity that we've seen. Of course, we have to always remember when we look at checkpoint inhibitors, we're challenged to a whole new list of potential toxicities that these patients are at risk for while they're receiving the therapies. So this is a new management challenge that we have as medical oncologists. But for this disease, I think these are risks that are worth taking for the patient, because generally these can be managed if they're recognized promptly. This data was strong enough to also get this agent and regimen added to the NCCN guidelines as well as the AGO guidelines. And I think I will end there because I'm supposed to stay on 45 minutes. I was going to touch base about the AKT inhibitors, but we'll end it there so we stay on schedule.